bit about my background, and then we'll get on with the topic. And every now and again, I'll just let people in from the waiting room as they join. Okay, so this is the busiest slide you'll see this afternoon. For me, it's this afternoon. I'm 3 hours behind you. I'm in Morocco at the moment, but for you, it's evening. And that's simply to show you that actually all the courses that we run are accredited. Some of them have multiple accreditation from several of these organizations, and all are, apart from NLP and coaching, which comes from the States, because that's where Richard Bandler, who originally created and invented and co-founded NLP, is based. But all the others there, apart from this one here, and that's from Canada, the Canadian Psychotherapists and Counselors Association. And NACBT, which is the National Association of CBT, is also in the States, but the others are British because that's my background, and so mostly our accreditation comes directly from the UK. So that's Transformations focuses on delivering courses that are internationally accredited and of an international standard. And we're not really interested, quite honestly, in local things in the UAE, because they don't really understand a lot of what we do, and they don't have a straightforward system for accrediting. Some goes to the Ministry of Social Development, some goes to Ministry of Health, some goes to Ministry of Education. So we stick to directly getting our accreditation from the UK.
Okay.
If anyone wants to know about any of those things, they can always, again, ask me when we have our Q&A, but that's the main organizations that we're affiliated with and we have our accreditation from. And this one, I should mention this actually, NCP, which is the National Council of Psychotherapists, and there's also an international sister organization. They're the ones that as of next year we'll probably have as our main accreditation, because they are directly accredited with the Professional Standards Authority in the UK, as are these people, CNHC, which we're already accredited with. Okay, so this is so that you know that it's not just me telling you, you know, how great we are. This is us receiving one of 2 awards that we've received in the last few years as the School of the Year from the international network of training schools that deliver psychotherapy and hypnotherapy that are accredited by APHP. And this is Terence Watts, who's also the chair of APHP and the head of the Essex Institute, and many other very well-known author in the field, giving us the award. And we're showing off a bit there because you can see it's the Ritz Hotel in London. So that's where we actually did the handover of the award. And what that's based on is the quality and the quantity of the graduates that we train to British standards, to UK standards, most of which we do in the Middle East, because we were based in Bahrain and Dubai for many years. Currently we're based in Morocco, but we work across Morocco, the UK and the UAE, and we usually zigzag back and forth, but because of the situation lately, we're going to be in Morocco for some time, because we only just got back in September to Morocco because we were locked down in Dubai for over 6 months. So we had to get things sorted out here. So I want to just ask you now, just a couple of questions to see what you think about what you know, I can tell you, but anyone have any ideas about what the differences is between these roles in the field of mental health? Psychiatrist, a mental health or psychiatric nurse, a psychologist who can have a number of different specialisms, a psychotherapist, a hypnotherapist, a counselor, a pastoral educator, a social or community worker, or a coach that does executive or life or health coaching, well-being coaching. If you look up coaching on the internet, you'll find there's probably hundreds of different fields that people coach in. So I'm not going to ask you to go through everyone individually, but who in that list is different from any of the others? There's one particular category that can do something and has a background that's completely different from any of the others. Anyone know who that might be? You can hazard a guess. Unmute yourselves and just say what you think.
Can I?
Yep, go ahead. I don't know who's speaking. You need to just let me know, because not everybody's got pictures.
My name is Krasimira, and I think the psychiatrist is with medical school, and they study. They first have to be doctors, and after that, anything else. So
Absolutely right.
The medical,
absolutely right. Yeah. Yeah, so the psychiatrist is the only one on that list that has to train as a doctor, as a medical doctor, before they go into the field of psychiatry. And so that means that they can do what? What can they do that nobody else on there can do?
They can give a medicine.
Yes, they can prescribe medication. And if I tell you, I think this will tell you a lot about what we think about this, is that one of the compulsory books that our students who do their full-time, their part-time, but their full training with us to become certified psychotherapists and counselors, that one of their textbooks is called, it's actually a book that's called Cracked, by someone called James Davis, and it's a very detailed book researching and interviewing all the people in the field and so on. And the subtitle of that book is Why Psychiatry is Doing Far More Harm Than Good. Yes, they prescribe medication, and the problem is that they treat mental health as if it was the same as physical health. That's been the case for some decades now. And actually, this is nonsense, because mental health is to do with emotional and psychological states. It's not the same as a disease. It's not the same as a physical disease or condition, which has what we call an etiology, right? We know that there's a virus, a bacteria, a genetic component to it. That's not the case with mental health. And so a lot of psychiatrists are doing things where they have absolutely no training at all in therapy. What they do is they spend several years after they qualify as doctors studying people who are sick and learning from a manual that's called the DSM, the Diagnostic Statistical Manual, what drugs they should treat with which. But there are a few psychiatrists, and there's a growing body, we'd like to see more, who are saying, you know, this is nonsense. And even the person that actually runs who put together, who's the chair of the DSM, the manual that tells doctors what to prescribe for mental health. And by the way, they don't need to be psychiatrists to prescribe medication. Any doctor can do that. Any GP can prescribe antidepressants, so-called. The problem is that actually they don't work, they don't do the job. It's more or less a placebo effect. And in many cases, they actually make things worse and not better. And you don't need to believe me, you can check this out, and I'll happily send you references. All you need to do is to look at the pack insert warning about these medications as to what the so-called side effects might be. And several of the side effects include things like anxiety, increased anxiety, depression, and increased suicidal ideation. So the problem is, by tinkering around with the chemistry of the brain, that's not what good therapy is about. So the problem is with psychiatrists, they prescribe lots of medication. It's a vast amount of the health budget. In the UK, more than half the health service budget for everything, including cancer and all the rest of it, is spent on these so-called psychiatric medications. So I say this because it's a problem, because they're the experts in the field, but only those who choose or are lucky enough to go to a med school where they get some training in therapy actually know anything about psychotherapy or counseling. They just learn how to prescribe medication. So that's a big issue, because that doesn't actually fix things, as I'll talk about in my presentation. Mental health and psychiatric nurse, they do need to train as a nurse, obviously, but that's not the same as training as a doctor. So they might give people medication that the doctor prescribes, but they can't prescribe medication. And very often they have a more of a therapy, counseling kind of a way of working with people. Psychologists, I know we have at least one person who's got their master's in business or business psychology. So that would be like what we would call organizational psychology. I don't know if anyone else has got qualifications, but these are, a psychologist is someone does a psychology degree, but then they have to do a postgrad, usually 2 years, sometimes 1, but they have to do either a master's or a diploma to get to be one of these things: clinical, educational, health, organizational. And again, the problem, especially with the clinical, is it very much works hand in glove with psychiatry, and it tends to label people with these many different conditions that are labeled in the DSM, because we started out at the beginning of the 20th century with about 6 different mental health conditions, and now we've got over 400, and it's nearer 600 if you add all the subcategories within them. And the only reason they get into that book is not through detailed research, clinical research, research in a lab, research through observing large numbers of people. It gets voted in. So someone makes a case for it, and then a group of people say, yep, we agree, and it goes in. And sometimes they occasionally say, we think that should come out. So for example, homosexuality was voted out some years ago, whereas it used to be in there. And there is a big problem about this labeling, which is what I was talking to Maha about earlier. You label people as if they've got a thing, a condition, an illness, and they haven't. They have different ways of behaving, different personalities, and sometimes those can be problematic. No one's arguing about that. But how you then treat them, what you do with them, is why I personally like using a combination of CBT, hypnotherapy, client-centered counseling. I have many different things that I use, but CBT is a big part of that because it is very straightforward, very effective, and it's proven with research, which is more than can be said for most of this other stuff that I was talking about. A psychotherapist is someone who does, as you might imagine, therapy, working with someone therapeutically on their emotional and psychological state. And there are so many schools that we have a book that's about this big that our students have, because there are so many different schools in this field. And I know that can be very confusing and overwhelming, so I'm going to try and keep it very simple in my presentation. I'll just categorize that into clusters for you. Hypnotherapy, I mentioned because I said there's quite a few people trained in hypnotherapy, both with us and people trained through Illuminations and so on. And that is actually also noticed because it was the very first form of psychological therapy, which you'd never think when people think it's weird or some people think it's a bit flaky or fringe. It was actually the first things practiced by the original neurologists in the 19th century who founded what we now call psychology, and that includes Sigmund Freud. So these were medical doctors who studied neurology, and including the neurology of the brain, and they used hypnotherapy. It was very widely used in the 19th century by doctors because of its use in pain management and because of the ability to access the subconscious mind. Counselor is a word which, counselor is a word which is confusing because in some cases it means a therapeutic role and sometimes it's advisory. So a school counselor might be someone who's trained in therapeutic counseling, or they might be someone who's there to tell you you need to work harder, or these are the sorts of subjects you should study. They might be a careers counsellor, etc., who helps you decide what career you want to follow. But the two are different roles. Therapeutic counsellors don't advise people what to do. They listen, they respect the person they're working with, they practice active listening and respect for the person to help them find their own solutions. Pastoral educators are people who are in school where they give support, where they perhaps have a tutorial role in universities as well. And then we've got social or community workers who work with people, for example, in Dubai, with the Mother and Child Society, with some of the charitable groups, and sometimes for the Ministry of Social Development or Community Development Authority. And we've got coaches, which I mentioned before. There's so many different applications of coaching, but coaching is different from therapy. And I'll keep that simple by saying coaching is when you help a person to unleash their potential, to get better at what they do, to develop their skills. Whereas therapy is for somebody who thinks there's something wrong with them and they want to get that fixed. And sometimes, people come in thinking they want therapy and what they need is coaching, and sometimes the other way around. So we like it when people train in both coaching and therapy so they can offer the whole package. If they only know one, they have to refer if people need the other thing. So all of these people that you're looking at now on the screen are people who can use and benefit from learning CBT and applying it in their work. I haven't put HR and all that there, but anybody who works in a pastoral role with people. So I said I'd categorize psychology into some simple categories for you. So the first psychological approach is what we would call deficit psychology. And probably the best known in that field is Sigmund Freud. Most people have heard of Freud. And what they looked at was what was wrong with people. There's something wrong. Freud personally believed that people were cannibalistic, incestuous, violent, murderous, and society was required to keep them in control, but sometimes they got too repressed by that, and so then they would become neurotic. So the next wave, if you like, in psychology was what we would call behavioral psychology, which is part of CBT. And that says basically, well, there's something happening. People have behavior, they do things, they can be stimulated, they can be rewarded and punished. We can do things and get results with people, but it tended to focus a lot on animals initially. So Frederick Skinner is probably one of the best known figures in this field. We also have Pavlov, we've probably heard of, with his salivating dogs. So This has elements to it that are very useful, but initially it was very, very much what we would call deterministic. It's like, find out how to prod someone in the right way and then they'll respond. And there's an awful lot of that going on at the moment in the world in terms of governments imposing their agendas about the so-called COVID-19 pandemic, or some of us like to say pandemic, that's going on, which is you treat people a certain way, you feed them certain information, and guess what? You'll get certain reactions. And, you know, so as I said, it's useful, but we prefer to see it in the context of what we call humanistic positive psychology. So here we're starting to get into that. There's something right. This is known as humanistic psychology, sometimes called psychology of being. And one of the best known figures of that was Abraham Maslow, and you've probably seen Maslow's pyramid of needs, where you've got at the bottom survival and food and all that, then you've got shelter, safety, interaction with other people, and at the top of the triangle you've got what he calls self-actualization, which is about something more than just surviving, something more than just being an animal. And then what we're into now, the wave of psychology that's been coming in since the 90s now, which I find very, very inspiring and optimistic, is what we call positive psychology, and that's the idea there's something better. Everyone can actually build on the strengths that they have, what's right with them. And by the way, as just so you know, if you didn't know already, Maslow was the first psychologist that started researching people who were well. He said, if we want to understand what makes people tick, what makes them behave the way they do and think and feel the way they do, why don't we study people who are well, who are doing fine? Until now, we've been looking at what's wrong with people. So positive psychology looks at what's the very best people can do. It researches things like flow states. When you get in touch with your intuition and everything just seems to go well, looking at sports, looking at musicians, but also coming up with a number of things that seem to work universally to help people to be happier, and to reverse the equation of, well, you need to be successful to be happy, to being the other way around. You need to be happy in order to be successful, in order to learn well, etc. And Martin Seligman and several other people, there's also Mihail, who they published, if you like, a declaration for positive psychology back in 1998, I think it was, which is only just over 20 years old, saying that they wanted psychology to support the idea of happy, healthy human beings, not all this deficit stuff. So I'm mentioning a couple of other people you might have heard about, especially if you've done hypnotherapy or NLP. We've got Milton Erickson, who is an American psychiatrist, a fascinating person, who found that talking to people in certain ways would induce a state of deep relaxation, the trance state as it's sometimes called, so that he could then influence the subconscious mind in order for people to get better, to feel well, to be more empowered. So most hypnotherapy training incorporates Ericksonian hypnosis, or what's known as Milton model hypnosis and hypnotic language patterns. I'll also mention NLP because it's a form of educational process and self-help, but it was originally called therapy, and it certainly can be used in therapy and therapeutically, and that's neuro-linguistic programming. And it was based on the work of these three very influential therapists, one of whom I just showed you before, Milton Erickson, and then we also had Fritz Perls, who was the person who invented Gestalt therapy, and Virginia Satir, who was the mother of what we call modern family therapy. So what John and his then partner, they split later, John Grinder, worked with Richard Bandler to actually study how these therapists actually got people to change by using language, and developed a whole system which is called NLP, which we also teach and incorporate into our work with students. And it has a lot in common, by the way, with CBT when it comes to the way it uses logic and reason and Socratic questioning. And these are the guys I mentioned, Martin Seligman and Mihail there. You can actually, there's a YouTube video telling you how to actually pronounce his name correctly. And this was, 1998. And so since then, they've been researching and doing a lot of work in this field. And there's some really exciting developments where neurology and psychology are starting to work together to see these things are effective across cultures, across age groups, etc. So it's a very exciting time to be working in the field of psychology. I'm also going to just mention that we have a bunch of stuff going on in the field of energy, if you like, psychology. EFT, meridian therapies, you've probably heard of some of these, especially if you've been working with Illuminations, Reiki, access bars, theta healing. We have traditional approaches, intuitive and scientific. People like Deepak Chopra, Joe Dispenza, Bruce Lipton, etc. Lynn McTaggart here, writing about the field, what they call the 0-point field, the placebo effect and epigenetics, the fact that we can change our genetics by what we think and feel. So these are the main different fields in psychology now. So I'm going to focus on CBT, and please feel free to chip in, ask me a question if you're not clear about something I'm saying, but I want to go through these slides so that you've got the basics, and then we'll have more Q&A time at the end. So the ancient roots of CBT actually go right back to Greco-Roman times and also to Eastern philosophies. We use what we call an inductive Socratic approach to reasoning. So you've probably heard of Socrates, the philosopher, and that's about getting from the specific to the general. So in CBT, if someone says something like, oh, I'm no good at whatever it is, that's not acceptable. We want to know what specifically do you find difficult in this activity? If you say, oh, I'm no good at talking in public, okay, specifically, when have you ever talked in public? Have you actually talked in public? If you did, what happened? So we get right down in what we call in NLP, chunking down to the nitty-gritty, to the specific details, before we then start chunking up again to the general. It's also influenced by the Stoic philosophy, the philosophy of the Stoics, who were the ones who cultivated, if you like, emotional disassociation, that you don't get involved in petty things, you don't get involved in gossip, you don't go, oh, it's a disaster when some small thing happens. You cultivate a degree of being calm and being mindful and not being bothered about what's going on around you. So the Stoic philosophy influences it, and there's some influence also from the four humus theory of personality in medicine, the original idea about that the organs each had humors or emotions and working with that. And in the latest variations of CBT, mindfulness-based cognitive therapy, there's actually a master's program at Oxford University in the UK, which incorporates CBT interventions, which I'm going to go through with you, but also incorporates Buddhist mindfulness practices and meditation techniques as part of that. The other one is going further east into the Buddhist side of things, and the idea of Zen and that tradition in the Far East. We have also what we call dialectical behavioral therapy, which is another variation on CBT. And this combines cognitive behavioral techniques for emotional regulation and reality testing with also techniques for distress, tolerance, acceptance, and mindful awareness, largely derived from Buddhist mindfulness practice. So it has a lot in common with the mindfulness-based approach that I mentioned on the previous slide. So it's all about accepting yourself, not evaluating, not being judgmental. And because CBT puts a big emphasis on change and changing yourself in the way that you want to, DBT says actually we need to change in a way that's not too confronting, that doesn't make someone feel overwhelmed. So it's a balance between change and acceptance, so that people can accept themselves as they are, not judge themselves, and then move forward at a pace that suits them. And Marshall Lynham, the psychologist who developed this, worked a lot with people with borderline personality disorders and fairly extreme mental health conditions, and found that it was very helpful. And DBT also uses not only individual therapy, but also uses a lot of group therapy and a teamwork approach between therapists, doctors, social workers where appropriate, and they also keep in touch with the client between sessions. So it has its own particular way of doing things. So if we go to the principles behind CBT, as I mentioned, they go back a long time. If we look at the quote that's supposed to have been made by Gautama Buddha, so we are what we think, all that we are arises with our thoughts, and with our thoughts we make the world. So he's not just talking in a philosophical, spiritual sense here, but what CBT says is this is literally true on a day-by-day basis. So I mentioned before Skinner, and I mentioned Pavlov too. So these people started out working, as I said, with animal behavior, You may have heard of Pavlov and the dogs, testing the dogs and getting them to salivate by ringing bells even when they weren't getting fed. We go into more detail of this on the course about how that worked. And then we went into Skinner with operant conditioning, a radical atheist who believed that humans' belief in religion and their religious behavior is no different from pigeons. He actually wrote a book called The Religious Behavior of Pigeons, because he trained the pigeons to come and do sort of certain movements of pecking and trying to find the grain, and got them to associate that if they did that, they would get fed. So they believed by doing this, they were getting fed, and actually he just set them up and conditioned them that way. We then started to get a bit more humanistic elements coming into behaviorism, with Wolpe developing systematic desensitization. So instead of other people doing it to us, conditioning us, we could do that to ourselves, what he called unlearning fear. And he was the person that developed what nowadays is called assertiveness training. I know Maha came on the introductory session I did to that. So actually training yourself to respond differently so that you don't get triggered by the same sorts of things. He also, for those who do EFT, developed the SUDS, the subjective units of discomfort or disturbance, so that you assess for yourself how uncomfortable you felt, how stressed you felt by different sorts of triggers and situations. So there's various other people there. I won't go into detail about them. We mentioned on the course. So these are the two people responsible for what we now call CBT. And actually, the original, the older of the two was Albert Ellis. And the thing about Ellis is that he died considerably before Beck. Beck is actually 99. He turns 100 next year. And he's still alive, and he's still working and research active, and works with his daughter who runs the Beck Institute. Now, Ellis was a psychologist, as I've said here, radical humanist. He worked with Kinsey, but he was a psychologist who felt, well, psychology is all very well as an academic discipline, but how do I help people? So he trained in psychoanalysis, which was the main therapy at that time, but he found it ineffective. And so he started looking at how he could develop more active and directed form of therapy, in which the therapist's job is to help the client to understand that their core irrational beliefs lead to emotional pain. That's what we call catastrophizing. And he developed something called the ABC technique. Now, completely independent of Ellis, Beck, who was a bit younger, but not hugely younger, but definitely younger. So sometimes we call Ellis the grandfather and Beck the father. So he was a psychiatrist. So he was, as we talked about before, a medical doctor who then wanted to help people, found psychiatry didn't really have therapy in it. He didn't want to just dispense drugs. So he trained in psychoanalysis, just as Ellis had done. And again, he found it wasn't effective. One of my ways of describing traditional analytic therapy is to take the example of Woody Allen, you know, the film producer and comic humorist, regardless of his history or claims of sexual abuse, but just, you know, who is a comic who's made funny films, clever films over the years. And he is someone who's had decades in therapy, psychoanalytic therapy, and you could say, like many people who've had that kind of therapy, intellectually he understands his problems very well. He knows he has a fear of death, a fear that his penis is too small, a fear of powerful women. So he understands them intellectually, but he doesn't actually have a way of stopping or dealing with or changing his responses to these things, other than by maybe using a bit of humor. So Beck, just like Ellis, found that it didn't help him when working with his clients, and he worked a lot with people who were depressed, who had serious depression, anxiety, suicidal ideation, and he also worked with schizophrenics. And what he found was, again, a model of what he called cognitive processing, where people learn to change their negative thought patterns, and he called that cognitive therapy. So CBT is actually put together out of a combination of these two, a combination of cognitive and behavioral therapy. And you can see them together there. They actually didn't meet throughout their lives until they were getting on in age. And in fact, Ellis died not long after this picture was taken. And they realized they had a huge amount in common. They'd come to the same conclusions. Many of their techniques were the same. And they agreed it would be really useful to collaborate and to start working together. But as I said, sadly, Ellis died. So the one who's perhaps best known nowadays is Beck, but actually Ellis had the heads up because he was older and he started it first. So the common elements, the common features of CBT are focusing on the here and now, that the therapist has a more of a directive or guidance role. They don't just listen and feedback what they've heard the client say, and they structure the sessions, and they have techniques, specific techniques that they ask their clients to follow in order to bring about change. And it's what we call a 50-50 partnership of therapist and client. So the ultimate goal, if you like, of CBT is for the client to become their own therapist. So CBT is based on the idea that our thoughts, what we think, affects how we feel and how we behave, how we act. Emotions, how we feel, affects what we think and what we do. And behavior, what we do affects how we think and how we feel. So it's what we call the triad, the cognitive behavioral triad: thoughts, emotions, and behavior, and how they affect each other. So the client starts to understand for themselves, with the clients getting help from the therapist, how it is they come to feel a certain way, how they come to behave a certain way, and what they need to do to change their thoughts to get different feelings and different behaviors. So that's to put that simply. So cognitive means anything that goes on our mind, including memories, images, thoughts, and attention. Behavior is everything we do, what we say, how we act, and how we avoid action, how we solve problems. And of course, therapy is a systematic approach to combating a problem or illness or a regular condition. And the central concept in CBT is we feel the way we think, and then we act accordingly. Now, I'd like to say a little bit about motivation, because this is very important in CBT. Motivation, in other words, if you're going to change, if you're going to start changing the way you think and feel and behave, get over negative habits, negative states, then you need to understand what makes you tick and what motivates you. And those of you who work in the field of coaching will know this is a biggie in coaching, because people will often start out enthusiastic, they want to change, and you know, we all make New Year's resolutions, and by the end of January, they've usually gone out the window. And that's largely because a lot of motivation to change is what we would call extrinsic, right? It comes from a belief, this is what I ought to do, what I need to do, and it's often driven by external factors. Operant conditioning, what I mentioned before. Society says you should do this, you should do that. Your mum, your dad, your teachers, everyone around you tells you this is how you should behave, but it's coming from the outside. And this is a problem when ideas, when advice, when guidance comes from the outside and is not intrinsic, the person doesn't really engage with it, it tends to go in one ear and out of the other and not make any difference, or not for very long. The one element that extrinsic motivation has in common with intrinsic motivation is what we would call social cognition. And that's to do with, I believe nowadays it's being called virtue signaling. It's wanting people to feel that we're good people, you know, in the whole COVID situation, you know, mask wearing, etc. Do it for others, even if it's not good for your health or you don't like it. You want to be approved of, you don't need people to say, oh, you're a troublemaker, you're challenging the status quo. So we do have an internal desire, think of that pyramid of needs I mentioned, to be accepted, to be part of the community. And so extrinsic Thank you. We were looking at motivation to learn. So if I just move through cognitive affective structures in CBT, I'll do this as quickly as I can so you get the gist of it. So in CBT, what we're looking for is how people represent themselves in what we call self-schema, and that we have a package of knowledge about ourselves where we have concepts about who we are, the kind of person we are. So you can see here, I'm a friendly person, a people person. On the other hand, someone says, I don't trust others, I'm shy. And we put together these beliefs about ourselves into a package of self-knowledge, and that's how we represent ourselves, and that's how we think of ourselves as being that sort of a person. Now, what Beck found in his research, and he did a lot of research from the 60s onwards, as I say, he's still research active, and he found a very high degree of correlation, which later we would now say is actually strong enough evidence to be causation, that the severity of depression and the degree of negative self-evaluation and pessimism was actually what determined the person's view of themselves. So what Beck found was that there was what he called a cognitive triad in depression. And you can see the negative view of the situation, the person thinks of the situation negatively, they have a negative view of themselves, and they have a negative view of the future. So when all those three are in place, somebody suffers from what we would call depression, and if they continue in that way, circumstances don't support them, they don't get any therapy, then they're likely to become long-term depressive and think of themselves that way. So the purpose of CBT is to help people to first of all identify what are the thoughts and beliefs that they have about themselves by self-monitoring and by education, so that people become more aware of what they're thinking, what they're feeling, and then what they're doing as a result of that, so they can understand the relationship between the thoughts, the feelings, and the behaviors. So in this model, we have an information processing model, which says there's the stimulus, there's what goes on in the outside world. We have a thought about that, and that leads to the emotion. And so in other words, it's not what we experience, but how we interpret it that determines how we are and how we behave. So one person in a situation could interpret it in a positive way, someone else could interpret it in a negative way, and they will both have completely different responses to the same situation, depending on how they process that. So the thoughts mediate between the stimuli and the emotions, and that stimulus elicits a thought, and that might be an evaluative judgment of some sort, might say it's a disaster, everything's terrible, or it might be a positive emotion. So this actually links with what Virginia Satir said, not from CBT, but many therapists have said things like, okay, it's not life itself, but how we respond to it that counts. It's not what happens, it's how we interpret it and what we make of it that counts. So CBT focuses on changing negative evaluations, negative thoughts, into ones which are more realistic, and not necessarily just switching them into a positive, like the sign that shows there, but actually more like testing them, reality checking. Is that actually true? So the clients are encouraged to notice and record their emotional states and triggers, and things like journaling, keeping a log of daily activities, filling in forms. CBT is quite big on forms for those who like to fill them in. Personally, I like journaling better, but I use forms for people who like to have the forms, and to start to actually have a more objective view on what's really going on, rather than the negative generalization that goes on that then leads to a trigger for a negative feeling, and then the whole thing goes into a negative cycle, self-fulfilling prophecy. So a thought process causes a feeling process. So here someone has a thought, I'm never going to have a good job. So they feel hopeless, and they probably don't even bother to look for a job, to fill in their CV, because they've already decided it's no good, I'm never going to have a good job. Someone else might think nobody likes me, feel lonely, rejected, so therefore they never go to social situations, they don't mix with people, they withdraw, and so therefore they fulfill their belief again. Someone else might think, oh, I've got this problem, but I have solved problems before, so let's see, what can I do about it? Not, as I said, just completely everything's hunky-dory, positive, la-la, but actually, let's see. Did I actually solve problems? Well, yes, I have. So let's see how I might solve this one. So then you start to get into a hopeful and positive state. So in the first stage of CBT, it's about normalizing, getting the client's depression scores back into the normal range. And you can see that CBT uses a range of behavioral techniques. And that's why I said it's very flexible. It fits with hypnotherapy, with NLP, with mindfulness techniques, with a whole bunch of things, breath work, to induce the relaxation response, having a list of daily activity schedules so you can check out what actually helps, what doesn't help, pleasure ratings to start using the, I mentioned before, the subjective units of discomfort or disease to see what things actually give me pleasure, what things make me feel okay, what things really don't. and experiments which include controlled exposure. In other words, exposing yourself to something that previously triggered a negative state, but in a controlled way, just a little bit, just to a degree, taking baby steps at a time. So the purposes in the CBT program is to identify and challenge those negative thoughts, analyze the errors in logic which depressed people normally make, to use the Socratic or inductive questioning method and guided discovery to challenge those thoughts and rewrite them in a more balanced way. So not turning everything into a complete positive affirmation, but checking out, is that really true? Have I always made a mess of things when I've presented to people? Have I never had anybody speak to me nicely when I went to a party, etc.? And start to get a reality check about what's really going on. 5 sessions minimum to learn to identify and challenge the automatic negative thoughts and the things that trigger these. And then the client starts to notice what was going through my mind just before I started to feel this way. And together with the therapist, the client draws up a list of several presenting problems and what are the likely thinking errors that went along with those. And the client also starts becoming their own therapist. As I mentioned earlier, they start observing themselves, disassociating and reality testing as hypothesis. Is that really true? Let's try out this and see what happens. So rather than taking thoughts as facts, to check them out and see how accurate are they, how realistic are they. And the client can actually capture these by using a voice activated dictaphone. You know, mobile phones nowadays have them in. Personally, I like clients to write things down because thinking uses a different part of the brain than talking, and it actually tends to bring in logic and reason when we write things down. So it tends to give us more of a sense of perspective and be rational and be able to see, oh yeah, that's an emotional reaction, but that's not actually how it is. There's been a lot of research done on CBT, and it's been statistically proven now, not a hypothesis, but it changes brain chemistry without medication. And in fact, in the UK, someone, I think it was Maya, said to me earlier, which therapy do you go for? Well, CBT is the go-to form of therapy for most doctors, health services, and so on, insurance companies, because it's had a great deal of research done on it, which shows consistently that it does actually change the responses, people's thoughts and feelings in a long-term way. And Beck and his followers have said they've actually conducted over 400 clinical trials to find that CBT is effective not only for the personality disorders that I mentioned, but even for things like schizophrenia, sometimes in combination with medication. So you can follow up, if you like, the links to see just how many things it's found to be beneficial and helpful for. There's a study that was done in Canada, in Toronto, where they actually compared people, the results as a result of using cognitive therapy and pharmacotherapy, in other words, using drugs. And they used pre and post treatment brain scans. And what was really interesting was that both drug therapy and CT actually changed the brain, but with the cognitive therapy, the changes were top down. With the drugs, they were bottom up. In other words, the drug worked on the amygdala, on the anxiety and primitive part of the brain, which as soon as you took the drug away, the same problems would come back, the same behaviors would come back. Cognitive therapy was changing a person's responses, their thoughts, their feelings about it, and that led to changes, in other words, top down. And so the antidepressants, they dampen the activity in the limbic system, but the CBT calms the activity in the cortex, in the brain seat of reason. So that's one of the reasons we know that CT and CBT are long-term in their effects. They have far less of what we would think of as being relapse. So whilst pharmacotherapy doesn't change the brain permanently, CT does. And Beck states, and he's very careful not to overdo his claims, but he says cognitive therapy does seem to be a cure sometimes. And I think most people would say nowadays, it's actually, that's a very modest statement. It is very, very effective. So you can use your own techniques, you can incorporate things that you do that work well for you and your clients into cognitive behavioral therapy, including hypnotherapy and other modalities. And I'll just go through, as I said earlier, I would do about comparing CBT and hypnotherapy and the relaxation types of therapy that work with the unconscious or subconscious level of the mind. Both are structured and focused. Both get results in a relatively short time frame. CBT uses around 15 to 20 sessions maximum, and so does hypnotherapy, but likely to be less with hypnotherapy if they're longer sessions. CBT uses specific instruments and diagnostic techniques using questionnaires and so on that Beck has developed a lot of those. A lot of focus on measurement, improvements, self-measurement, self-improvement, how clients and patients rate themselves. Hypnotherapy sometimes uses an initial questionnaire and a questioning style, and the pre-talk vary by therapist and approach, how they've been trained. Our people we train tend to be very thorough with their initial questionnaires. Both focus on identifying core negative beliefs, one by using conscious processes, the inductive questioning, and the other by using subconscious processes in hypnotherapy. You actually find that the two together work extremely well in combination, with the pre-talk using this CBT approach and then the hypnotherapy session using the subconscious dialogue. Both use reframing, one using conscious awareness to assess core negatives against reality, the other using parts therapy, ideally aiming to unite the conscious and subconscious awareness, focusing on a single idea at one time. Both focus on specific negative thoughts and feelings and seek to replace them, the negative with positives. Both set a series of structured goals for change, although hypnotherapy is less structured usually. CBT puts a big emphasis on homework tasks or self-help tasks, if people don't like the term homework, reinforcing new behaviors over time, including things like controlled exposure, as I mentioned. Some hypnotherapists do set self-help or homework. They use reinforcement audios, others don't. And some just rely on immediate change through the use of suggestions or instant cure or fix, especially if they're using an NLP approach. Both use suds and shifts measures, but it's always used in CBT, not necessarily in hypnotherapy. The main big difference is that CBT doesn't focus on the past. It doesn't conduct regression. The focus is on the here and now and building for the future, whereas those of you who know anything about hypnotherapy know that we do conduct regression and conduct analytic work, parts therapy, to clear repressed material and trauma. So again, you can actually have just CBT on its own, you can do hypnotherapy on its own, or you can combine the two, and this is actually extremely effective. So as I've got a mention here from evidence-based mental health, when we combine hypnotherapy and CBT, substantial improvements in the outcomes. So actually, it's a very complementary way of working to combine hypnosis and hypnotherapy with CBT. So both are active, both CBT is directive, hypnosis can be directive, both are time limited, both are structured, both are problem solving and solution focused approaches. And as I said, we want to do more research on this. And CBT particularly is good for changing maladaptive, rigid ways of thinking and feeling. And it's, as you can see the list there, much the same as hypnotherapy and a number of other effective forms of therapy. You can work with all of these things. I would say that for eating disorders and OCD, and also with depression, those particular conditions and problems that people suffer are much more effectively treated by using a combination of CBT and with other modalities where somebody's trained in those, particularly hypnotherapy, I would say. So the last slide I have for you, and then as I said, I'll take some questions. We are shorter than we would have done in terms of time, but I can go on longer if any of you need to drop off sooner, I understand, but we should have 10 minutes or so. So we're running a two weekend intensive course, not this weekend coming, but the one after and the one after that, because my timing in Morocco is 3 hours behind yours. We start at 11 and we finish at 7. And the course fee includes the exam, and there is an exam which comprises questions, a case study, and a multiple choice question, a set of questions. It's not for complete beginners. If you don't know anything about any form of therapy or coaching and you've not had any experience in this field, then it's not going to be suitable for you. That we assume a certain level of understanding about communication and behavior and some basics about not psychology academically, but how people tick. So anybody that's working in a field of the caring professions is likely to benefit. We've had people who are school counsellors, people working in HR, people who are coaches, NLP coach practitioners, as well as therapists, counsellors and psychologists, psychiatrists. Many people working in the field of mental health have come to add the CBT skills to their toolkit. If you're a complete newbie, then you would need to think again. We're for next year, we're going to start a new course. We've been running 2 years of diploma in 1 year and a second year of diploma, advanced diploma, but we're actually going to be teaching the integrative psychotherapy and counselling course, which we hope will be from September next year, but that's going to depend partly on the accreditation process we're going through right now, because they're having to change everything because so much more is now having to be done online. So, as I said, I'm aiming for September next year, but I won't know for sure until probably the spring, when we see how the whole thing pans out with international travel and so on. So that's the slides that I wanted to show you. I think we've got most of you still there. We've lost a few people. Sorry about that, as I said, just circumstances outside of control. So who would like to ask me any questions or any comments? You've got anything specific that you want to ask, or a more general question, please go ahead. Just unmute yourself so you can speak to me.
Hi, Doctor, so much for that. It was really good to follow theory, and thank you for that. I just wanted to inquire, when you say accredited as a course being accredited, is it part of BPS or is it something else?
Sorry, say that last bit again.
Is it accreditation? Is it part of BPS?
No. BPS doesn't really get involved in anything other than if someone has put it this way, someone has a background as a psychologist, either excuse me, a graduate of psychology, or they're a BPS member from, say, doing psychometric testing or something, then yeah, but we don't get involved with BPS because it is the British Psychological Society. We work with organisations that are more focused on therapists and counsellors and so on. So the accreditation for this course is multiple. It's actually Dr. David Cato's course, who was a prominent practitioner of CBT and hypnotherapy. He ran the Bristol Depression Clinic for many years before he retired, and he's considered to be one of the most successful therapists combining CBT with, as I said, he also practiced hypnotherapy. And they have a couple of international organisations. There's the AIC, which is the Association for Clinical Hypnotherapy, continued hypnotherapy training. We've got Essex Institute, which is Essex Institute for Clinical Hypnosis and Psychotherapy, which comes under CNHC, I mentioned before, the Complementary and Natural Healthcare Foundation. As I said, there's a number of groups in counselling and psychotherapy because it's what we call voluntary regulation, right? It's not legal regulation. So BPS, as I said, no, we don't really go in for BPS because they're very, they're very sort of cliquey, and they approve certain things and not other things, so we don't really work with them. But it's not necessary to work with them. As I said, people have already got, excuse me, I'm getting a bit of a dry throat now. People who are already psychologists can add this, as I said, into the mix, but people who are, say, coaches, they would just want the diploma to say, yeah. What would I say also? Oh yes, the Open College. The Open College in the UK accredits the course. I think it's a level 3. So there's a number of different routes for accreditation, but mostly I find that people who want this course, they want practical applied skills, and then they can add that to their, obviously, to their CPD. So it counts for continuing education units for the number of hours that you do with it. So it's, I think it's something like, it's around 30 hours, something like that, of accreditation for doing the whole thing. There's the 2 weekends, and then we sometimes run one that's a diploma in eating disorders and OCD, which is again primarily using CBT, but also some other modalities. And I try to adapt the course a bit depending on who's on it. So if they're a hypnotherapist, we'll give them plenty of hypnotherapy suggestions. If they come from another background, we have people sometimes say who are energy workers or breath workers, or they have another background. So I'll tell them these are the times you can use the CBT. this is when you can switch and do something else instead. But that's why I like it, is because it's flexible. You know, it's not one of this is how you have to do it. Of course, some people love CBT and they really get into it. And then we'd recommend that they did another course, like a longer one with the Beck Institute or something similar. So they become a specialist in CBT. Whereas I regard myself as being, I'm certainly specialist enough to train in it and to use it, but it's not my only modality. I started out as a Rogerian, and I also practiced, you know, a number of different things, breath work, different kinds of approaches, very much coming from a developmental point of view in psychology with child development and all of that. And I started, later on, I started to use hypnotherapy because I found it was so effective. And then when I got into CBT, I found, as I said, that combination was a really, really excellent one, because when you're doing the pre-talk in hypnotherapy, a lot of people don't do that very well because they're not trained as psychotherapists or counselors. And the CBT gives them a great structure to do that. Also, if someone's an NLPer, they'll find it makes great sense, like the meta model, to analyze the surface structure of language, to see the generalizations, the deletions, the distortions in language that people then label themselves with in creating their map of the world. So CBT and NLP, and as I said, hypnotherapy or the relaxation techniques go very, very well together. Does that help with your question? Great.
Yes, it does. Thank you very much.
If you've got any others, then you're welcome to ask. Coaches use it in their coaching. You know, again, if you're a coach and use things like the Wheel of Life or the GROW model, again, it fits beautifully into the GROW model, because you're going to set the goals to be specific. You're going to use the R, the reality checking, reality testing. Then you're going to look at what your options are. Then you're going to have the way forward. So all of that, the Wheel of Life, the standard sort of coaching techniques, 360-degree feedback, all of that fits very nicely.
The Hari window, all of them. Yeah.
Yeah, exactly.
Yeah. No, my only thing is because since the world is so finicky about accreditation and making sure we are getting trained from the right places, I was just wondering, if I do the course, then I can end up saying that I'm CBT trained.
Yes, absolutely. Once you pass the exam, and the exam, people usually pass the exam very well. If they've attended the course and they've studied the materials, it's all in there, all they need to know. Obviously, the bit that tests them out that they've really paid attention is the case study, because you can't find the ready-made answer for that, like you can for a multiple choice or something. But the minimum mark is 75%, and we very rarely had anybody who hasn't made that first time around. They're allowed to retake if they need to, but we very rarely need that. And a lot of people get between 85, 90%. I had somebody who got 100%, she didn't get 100% on both papers, but on one paper she got 100%. So it's not, it takes work to do the exam, but it's not difficult as long as you've got the material. But then once you've done it, you will get a diploma that actually says you have a diploma that you've demonstrated competence and, you know, professional competence to safely practice CBT. And it's signed by myself and by David Cato as well. And it's got the mark of the Open College and Ars Transformations Institute, and also I'm trying to remember. Anyway, it's got several logos of the associations that approve it. Yeah, so you'll definitely have that once you pass the exam. And we usually allow 4 weeks after the course in the current circumstances. It used to just be a week, but now because of doing things online and working from home and all the rest of it, we give people 4 weeks to actually do the exam and submit it. Okay. Any other questions from you or anyone else? I'm very happy to address them. Those of you I didn't get a chance to have a chat to earlier, sorry for that. Deborah and Ultima and Accredited and so on. I'm sorry we missed 15 minutes of the session with first the power cut here and then going offline and having to drag in another router. But doesn't usually happen, but it does occasionally. We have a generator with the power cut. So in Morocco, you always have a generator to back you up because the electricity is very unreliable here. But we teach sort of 7-hour sessions, so we have to be prepared with backup. Anybody else got any questions or comments or observations, anything at all? I'm very happy to take them. And as I said, if you're not rushing off for the next 10 minutes or so, I'm happy to make that time up that we lost if you want. I just rushed through the last few slides a bit to make sure that you got them. Okay, anyone else got anything?
Layla, could you give us a little bit of information about the format of the 2 weekend courses, how the training goes on those days?
Yeah, well, actually, you'll get that in detail if you go onto the Illuminations website. You'll have a list of all the curriculum that we cover. Just hang on a minute, and I'll just have a look and see. Sorry about this. I'm just looking to see if I've got the summary of the curriculum here to hand. Well, anyway, what I'll tell you is that the first part, I tell you how the rough structure goes. I can't go into detail with it unless I dig around here for it. But how the thing goes is that the first weekend we focus on covering the basic model. You know what I just touched on and gave some examples on here. So we go into more depth about the history, about behaviorism, about CBT itself, about the structure of it, and how those 15 sessions are usually held, how we can shorten that down to 6 sessions by using some other tools and techniques. You get given, if you don't know anything about hypnotherapy, we give you some scripts and some kind of language that you can use to actually induce the state of relaxation. So that's on the first weekend. And then the second weekend, we also then look at the psychology of depression, grieving and loss. Because as I mentioned, Beck did a lot of work in the field of depression. And let's face it, if you work in the field of mental health or even in coaching, you will find that a lot of people, whatever they're coming forward with, grieving, loss, depression is something that many people have dealt with, even if not themselves, in their family. And we've all experienced grief, we've all experienced loss in some way. So it's important to get a handle on that. So we do go through Kubler-Ross's model and also Barry Hopkins' model of the cycle of change, the psychological pressure of change. And we look at some case studies and people are encouraged to bring their own material, anyone they've worked with, or who would be their nightmare client to work with, how would I approach this, etc. So it's heavy on the theory, more heavy on the theory in the first weekend on the CBT. Then, as I said, look at some applications. Then in the second weekend, more on the background. And also because if people want to know, I mean, I've been very disparaging, I know, about the DSM, but it's important that people understand what the labels are in the DSM that are used, what sorts of cases would be taken on, which ones you would avoid if you're a newbie or relatively, you know, haven't had a great deal of experience in this field. So we go through that in the first part of the second weekend. And then, as I said, we concentrate more on discussion, case studies, how you'd actually apply this stuff and make it work. So I don't know if that's detailed enough for you. But as I said, all that we cover is on the Illuminations page, but the spread of it, if you like, is first weekend CBT theory and practice, how you structure it, and then the second weekend is more about depression, grieving and loss and handling that and applying CBT and other modalities, how you might work those in, depending on who's on the course. Because I said I try to tailor the case studies and the work people might do with their clients depending on what their background is, whether they're coaches, whether they're already therapists, whether they're psychologists or psychiatrists. Does that answer your question sufficiently, or would you like to ask me anything else?
Yeah, that covers lots. That was great. And then as a follow-up question, in terms of the actual teaching part, is there interactive practical work? Do we do role plays, breakout rooms? Just so that how the format of the teaching goes.
Yeah, with this we do on the theory. Obviously, it's fairly when it's theory. I use slides to try and pull out the key points, because you get a really detailed manuals, one on the CBT and one on the depression, grieving and loss. So there's lots and lots of materials that you're given as you know, you'll get soft copies of. Also the forms, David Cato's own CBT forms, and you'll get directions as to where you can get some other ones from that you can download. And we give you 6 session scripts. So there's a lot of practical stuff you can go away and use and apply. But when I'm teaching, I tend to use a PowerPoint slide so that I can pull out the key points. I encourage people to ask questions or whatever they need to. And then I do use breakout rooms when we're having discussions, when we're having When we're doing any role play or case studies, yes, and so I put people into breakout rooms. As you know, online, the challenge of that is how much to stick your nose in and how much to let people get on with it. So what I tend to do, I've been doing this now for probably 7 or 8 months since we've had to go online, is that I put people into breakout rooms. Depends on the size of the group, whether it's pairs or 3s or 4s or whatever, and then I let them get on with it for a bit, and then if I think it's necessary, I'll chip in, I'll come and see how they're doing, but most often I let them do it for a period of time, then I pull everyone back and then we have a group discussion. But as I said, in my own course, we've got about, the advanced diploma that we've been teaching, I've got about 10 people, so I can play around with the numbers. With Illuminations, it varies. I know they've got about 4 people definitely registered already for the course, but if it's only 4 and we don't get any others, for example, I'll probably put them into some time for pairs, but we'll do a lot of the discussion together as a group of 4, because that's, you know, it's not like where you can put 10s, 12s and put them into breakout rooms of 3s and 4s and then get back together. But yeah, I do attempt to be as interactive as possible, but I say right at the beginning, there's a fair bit of theory in the CBT to get a hold of, but I encourage discussion, people to unmute themselves when they want to ask a question or to make an observation or a comment. I'm not, you know, I'm not just lecturing for hours and hours. I hope that helps to answer your question.
Yeah, that's great. Thank you very much, Leila.
Okay, you're welcome. Anyone else got any questions? Okay, so if if nobody has got any questions or any observations, then we can finish. If anyone still does, then please, as I said, go ahead, because you did have to have a whole missed out on about 15 minutes of when I would usually have taken that at a slightly slower pace. Death by PowerPoint. Okay. Anyone else? No? Okay. So if nobody else has, if you want to, I think I put you should find in the chat room, you've got my email address. So if anybody has anything they'd like to send me an email about, I do check my emails daily, and I usually get back within a day or so. And we've got, as I said, we've got until not this Friday, but the following Friday. And I do, I should say, I do send the materials out in advance so that people have a chance to look at them. And if they want to ask questions, but if it's questions that I'm going to cover later, I'll say, can you just hang fire on that one, just make a note of it. But all the materials will come to you. And after they've actually, excuse me, recorded the course, you get a link to the recording, so you can always watch it again. Obviously, I'll put it on pause for lunch. I'd say something about the structure of the day. We work from, if you're on Dubai time, we work from 11 till 1. Without a break. Then at 1 we have an hour for lunch, and then the afternoon we work through, but at some point, as close as I can manage to the middle of the afternoon, you get a 15-minute break, a comfort break. But people have said to me, oh, that's, you know, people can't manage, they won't concentrate. Actually, I don't find that's true. I found people have been very engaged, very interactive. We've had great feedback on the course. So I'm quite happy to stick to the longer days rather than doing lots and lots of separate days. And of course, in Dubai, when you have a lot of separate days, you'll find people saying, I can't make this one, or can I come to that one instead? But if you miss anything, if you do miss anything, you can get the recording that Illuminations will make, so that then you can have that sent to you. And I do also send out the slides after, but I don't do the slides before the course, because I'd rather talk you through the slides, then you get the slides. So you get everything from the course after, except for the manuals, which you'll get beforehand, if that is all clear to you. Right, so if nobody else has got anything, you've got my address, as I said, you can always post to me. I'll say my goodbyes to you and thank you for joining us today. And again, my apologies for the clunkiness of first the electricity and then the web gone down. That's the first time I've had both. I've had the occasional one or the other, but not usually both, and in such a short time too. So usually the students are forewarned when it's the longer courses. And so if I drop off for any reason, they know how to continue and do stuff amongst themselves until I come back. So, okay, so if that's it then, I'll say good night to everyone, and well, good night at your end. For me, it's afternoon. And hope to hear from some of you soon, and hopefully to work with some of you again soon when we run the next course, or the last course of this year that's planned. Okay, bye-bye everyone. Take care.
Bye. Thank you.
Bye-bye.
You're welcome. Bye-bye.